Good morning, afternoon, or evening to all of you. This is Bob Marsh from Beyond Clean, and I'd like to thank you for joining Richard Warburton from ChemDAQ Incorporated and myself to talk about chemical monitoring during the time of COVID-19. PPE shortages are presenting opportunities for extreme measures in healthcare facilities, specifically the prolonged use, reuse, and reprocessing of PPE such as N95 masks. Technicians who are performing mask disinfection or sterilization may be exposed to hydrogen peroxide vapor, and hospital staff wearing reprocessed masks could be subject to residual hydrogen peroxide offgassing. How do you ensure worker safety amidst all of these unprecedented processes? Well, that's exactly what we are going to talk about today. We will discuss how COVID-19 has impacted the cleaning and re-sterilization of PPE. We'll discuss the current practices concerning limited reuse of PPE. And finally, we'll talk about the need for off-gassing of H2O2 or hydrogen peroxide after sterilization. And now I'd like to turn it over to Richard.
Thanks, Bob, and thanks for the opportunity to all of you who are watching and listening to this webinar, for this opportunity to speak on this important subject. We definitely live in unusual times. As the coronavirus pandemic spreads across the country and the world, it is placing great burden on the healthcare systems. While the news has focused primarily on the lack of ventilators for patients, another major issue for healthcare workers is the lack of personal protective equipment. COVID-19 is highly infectious, and the normal protective gear, i.e. N95 masks, face shields, and other PPE is running out. N95 masks in particular provide the first line of defense, and the normal practice is to change the mask between patients so as to avoid transmission of disease from patient to healthcare worker and from one patient to the next via the healthcare worker. It is, however, very clear that the healthcare industry was not prepared for the COVID-19 pandemic, and undoubtedly the reasons why will be debated in years to come.
I know, Richard, this is really a big topic. I'm very bothered by how unprepared we found ourselves. It is disturbing that we've had healthcare professionals either reusing or not using PPE because it has not been available. Many of these folks have really been placed in harm's way due to our unpreparedness.
Yes, the issue faced today is that we see many healthcare professionals being forced to reuse single-use PPE or sometimes use homemade masks, or in some cases no masks at all. Healthcare professionals know that working with very ill patients without proper personal protective equipment presents a direct threat to them. This is a global problem, and already hundreds of healthcare providers around the world have died from COVID-19. And according to US News, more than 1,100 healthcare professionals in 35 states that track the numbers have already been infected in the US. Desperate times can call for desperate measures. Many of the current solutions are less than ideal, and they may impart additional risk to healthcare workers. The CDC offers advice as to what hospitals should do in the event of shortages of masks during a pandemic. There are various administrative things they can do, like limit the use of masks to essential personnel only, use the mask only where needed, and give the mask only to healthcare providers and not to patients. However, these measures are not so popular among those healthcare providers who do not get masks but still feel that they are vulnerable to infection. Another thing that the CDC recommends is the extended use of face masks. I allow the reuse of the same mask worn for different patients by the same healthcare provider.
I know, it's crazy. As the information on shortage of PPE became available, it was frightening to see how few resources were available to support hospital sterile processing departments. The only support came from the CDC with its limited reuse guidelines, and there was no information on how to properly clean or re-sterilize PPE.
You're absolutely right, Bob. If there are no masks, the CDC had further guidance, which was to exclude those healthcare providers who came from susceptible groups, as those who were elderly or who had pre-existing medical conditions. Include those healthcare providers who have already caught the disease and now recovered, and therefore presumably have immunity. Use exhaust ventilation where it is available. such as ventilated headboards, and as a last resort, use homemade masks. There are two classes of N95 masks out there, one for general industry, which is certified by NIOSH, and one for healthcare that are additionally regulated by the FDA as Class 2 medical devices. One of the measures that the CDC and FDA have taken is to broaden the rules so that non-medical masks can be used by healthcare providers. Even with these measures, a recent survey found that nearly half of all healthcare facilities that were surveyed were either out of respirators or almost out of them in caring for the patients with COVID-19. Some facilities are already relying on homemade cloth masks. However, homemade cloth masks can provide a false assurance, since an N95 mask will keep out 95% of all of the very small particles, whereas a simple cloth mask will often let them pass through.
Yeah, it's been really heartwarming to see the public really step up and make homemade masks, but it's been equally disturbing to learn that they actually could make matters worse, and they could harbor particles that could actually make the healthcare workers wearing them sicker.
However, many hospitals are so low on PPE that they're sending their frontline staff into care for patients without anything at all. Some people are looking to the federal government's strategic national stockpile. However, according to the New York Times, the national stockpile of medical supplies included 12 million medical-grade N95 masks and 30 million surgical masks, which sounds a lot, but this is only about 1% of the 3.5 billion, with a B, that the Department of Health and Human Services estimate will be needed over the course of a year if the outbreak reaches pandemic levels. N95s, as I'm sure everyone listening knows, are single-use devices. But the question is now raised, can they be disinfected or sterilized? This is not the first time that this question has been asked, since there have been pandemics in the past, such as the SARS coronavirus in 2002 and the H1N1 swine flu in 2009. A 2007 study tested several possible methods, including heating to 160 degrees centigrade, soaking with 70% isopropyl alcohol, or soaking in soapy water for 20 minutes, and found that all three methods caused significant degradation of the filtration efficiency. Another study published 2 years later looked at microwave radiation and steam sterilization and found that both methods destroyed N95 masks. They did find, however, that UV light, hydrogen peroxide, ethylene oxide, and bleach caused no damage. There were, however, some drawbacks. Even though ethylene oxide was not found to affect the physical properties of the masks, the long cycle times were considered to be a detriment. Typically in hospitals, an ethylene oxide cycle time is 10 to 12 hours. Hydrogen peroxide was also found not to affect the physical properties of the mask, though some masks were found to absorb enough hydrogen peroxide vapor that the sterilizer will abort. Bleach resulted in chlorine off-gassing even after the filter had been rinsed and dried. Bleach was therefore rejected because the off-gassing chlorine had a strong chlorine smell. UV light did not affect the physical properties of the mask, but UV light is only effective where the UV light can reach. And so there are questions whether the UV light can penetrate through an N95 mask. We did a quick test in our lab with a 3M N95 mask and found that only about 0.2% of visible light was transmitted through. White light is not absorbed by the mask materials, but UV light at these low wavelengths is. And so the chances of getting more UV through is low.
That's really interesting, Richard. So how can we clean and or sterilize PPE? We've always been told that if you don't have an IFU that you shouldn't re-sterilize or even sterilize a device. And we've been told that if it's not clean, it can't be sterilized. As studies have become available to healthcare systems, we've discovered that most of this re-sterilization technology or the modalities are unavailable. I'm speaking in terms of UV and ETO. Some facilities have it, but most have gotten rid of it. Numerous hospitals have begun sterilizing the N95 masks in H2O2 or hydrogen peroxide sterilizers with no real evidence to support the cleaning prior to sterilization. And this goes against everything they've been taught. When we think about when in doubt, throw it out, or if a device cannot be cleaned, it cannot be sterilized.
Yes, Bob, you are absolutely right. N95 masks and similar products can't be cleaned. The best people can do is to look to see if there's any visible gross contamination and discard those masks that have it. In practice, the masks are probably not all sterilized, but they will be more or less disinfected, and so the risk of transmitting infection to the next wearer is greatly reduced. Standard reprocessing of medical devices requires a two-step process. The first step is cleaning and decontamination, and the second step is high-level disinfection or sterilization. As we just mentioned, there is no practical way for N95 masks to be cleaned by a healthcare facility. Instead, they are inspected, and those with visually gross contamination are discarded. And only the visually clean ones are reprocessed. Since cleaning is impractical during reprocessing, this webinar will use the term disinfection rather than decontamination to describe the reprocessing of N95 masks. While some studies have shown that the various disinfection methods being used do destroy viruses, few of them appear to have demonstrated a sufficient sterilization assurance level, meaning that there is less than or equal to 1 chance in a million that a single viable microorganism is present on the sterilized item for the process to be described as sterilization. Even in those trials where apparent sterilization has been achieved with model systems, recycled masks are going to have variable biological deposits in them that the sterilant gas may or may not be able to penetrate.
So, Richard, if a healthcare facility doesn't have these other modalities for disinfecting these masks, can they still be sterilized?
The requirements needed to say that something is sterilized is very high. Less than a 1 in a million chance that a viable pathogen is still there. Hydrogen peroxide and ethylene oxide are both very effective disinfectants and sterilants, and they will disinfect all surfaces. But if there are any large globs of contamination, for want of a better word, the hydrogen peroxide and ethylene oxide are not likely to reach the interior, so the best we can claim is disinfection. One thing we need to keep in mind is that while hydrogen peroxide and ethylene oxide disinfection are not perfect, they are being used because they are better than the alternatives and far better than reusing N95 masks without disinfection. Ethylene oxide sterilization is the most widely used method for the sterilization of medical devices, and many new N95 masks are sterilized with it. Anderson Sterilizers just announced that they are working with the University of North Carolina at Chapel Hill, and they are able to reprocess 1,500 masks a day through 10 sterilization cycles. On a large scale, Medline Industries is also reprocessing 100,000 N95 respirators and other face masks per day in its sterilization facility in Redmond, Oregon, and is looking to ramp up to 250,000 masks a day.
That's very interesting, Richard. Ethylene oxide is known to be highly effective at killing spores. And it's also interesting to me that there's been a push in some facilities to eliminate it, even though the permissible exposure limits are the same for both ETO and hydrogen peroxide, according to OSHA.
Yes, Bob, you're absolutely correct. Hydrogen peroxide is the most common method of low temperature sterilization used in hospitals in the US. And hydrogen peroxide is widely used for whole room disinfection too. There are two approaches to hydrogen peroxide disinfection of N95 masks. The first uses a hydrogen peroxide sterilizer, and the second uses a room disinfection system. Sterilizers have the advantage that they are an established technology, but they can typically only reprocess small numbers of masks. The FDA has granted Steris an emergency use authorization to use its VPRO sterilizers to sterilize N95 masks. And ASP has a qualified protocol for reprocessing masks in its steroid sterilizers. Hospitals using the sterile system can reprocess up to 480 masks per machine per day. Assuming they're using the 28-minute cycle, that works out to only 10 masks per cycle. 3M has also verified the continued fit and filter efficiency for masks sterilized by both ASP Sterid and Steris Vipo sterilizers, confirming the findings from the University of Massachusetts and New England Baptist hospitals that the N95 masks were still effective at blocking infectious particles after sterilization. The second approach is room disinfection. Preliminary results indicate that hydrogen peroxide vapor is an effective virucidal agent when used to disinfect N95 masks using a room disinfection unit. The Duke School of Medicine recently announced that they are disinfecting N95 masks with hydrogen peroxide vapors before redistributing them to healthcare workers, and this process is being extended to other hospitals in their system. Battelle, out of Ohio, also just received emergency clearance from the FDA for its critical care decontamination system, which can decontaminate up to 80,000 masks per day using hydrogen peroxide. In a typical hydrogen peroxide room disinfection system, the device evaporates or mists a known amount of hydrogen peroxide, calculated based on the volume of the room or the chamber and the desired concentration. Hydrogen peroxide is then left for a dwell period during which the disinfection process occurs. It is then removed by drawing it through a hydrogen peroxide scrubber or vented outside.
So while this emerging technology is great, it brings huge challenges to mind for me, space being the first. Finding a separate space in a hospital to perform this type of disinfection can and will be a huge challenge for many facilities. If I don't have access to whole room disinfection, can I send our masks to another facility, another hospital, and ask them to disinfect them? If so, how would I transport them?
Very good question. Generally, the requirements for transporting masks to another hospital for disinfection will be the same as for transporting other used medical devices for reprocessing, as is described in AAMI ST79. However, since the N95 masks cannot be cleaned, the used N95 masks must only be placed in clean containers that hold N95 masks and no other devices waiting to be reprocessed to reduce the further contamination of the mask. The mask should be inspected for gross contamination before transportation, and each mask should be in its own Tyvek pouch or equivalent to avoid cross-contamination. On the return trip, the mask should be placed in a clean container, and each mask should still be in its individual pouch, packed in a manner that preserves its sterility or disinfection state. With room disinfection, the big question is, how do people know when it is safe to go back into the room after the disinfection process is over? Hydrogen peroxide is colorless and has essentially no odor, and so smell cannot be used as an indicator of concentration. The OSHA permissible exposure limit is 1 ppm, so a very low concentration, as may be expected for something which is a commonly used sterilant gas. If operators do not wait long enough before re-entering, they risk being exposed to dangerous concentrations of hydrogen peroxide. And if they wait too long, then they will reduce the throughput of mass disinfection at a time when availability is critical.
Yeah, so with the space and safety challenges that these healthcare facilities are facing, they've begun running masks in their sterilization processes with no cleaning or decontamination capabilities. Off-gassing is not something that's typically performed in a hospital. I would say that the majority of sterile processings are not even aware that hydrogen peroxide or H2O2 even needs to be off-gassed. These safety procedures are exactly what the industry needs right now, Richard.
I agree, Bob. As I just mentioned, hydrogen peroxide has no odor, and so it is imperceptible until the concentrations are much higher than safe levels. Therefore, the best method to know if it's safe to re-enter the room is to use a gas monitor for hydrogen peroxide. Off-gassing is the second issue that we also need to address. Here's a simple protocol for room disinfection. This is a protocol that's used by a lot of pharmaceutical companies when they are using hydrogen peroxide to decontaminate rooms. Step one would be to run the disinfection cycle as advised by the manufacturer of the hydrogen peroxide vapor equipment. They will say, put the device in there, run through its cycle, and then they will give an estimate of roughly when the cycle will be over. So the end of the cycle can come from the manufacturer's guidance. It's also possible to estimate when the hydrogen peroxide concentration will fall to a safe level if one has a good understanding of the rate of air exchange in there at the end of the cycle. The third thing is, if this is a repeat process, one can go back and look at previous runs and get an estimate of how long it takes. At the time when one thinks it should be okay to re-enter, crack the door and place a hydrogen peroxide sensor inside the room and close the door again. At that point, even if the concentration is a little high, it should not be an issue because the concentration should be fairly low anyhow. So just momentarily cracking the door should not cause a safety issue. Monitor the hydrogen peroxide concentration in there, and when the concentration is below 1 ppm, which is the OSHA permissible exposure limit, then it is safe to open the door and re-enter the work area again. If the monitor shows that reading was already below 1 ppm, then on the next run, one can shorten the time and use that experience to optimize the cycle time needed for the room disinfection. This is the typical procedure used for room disinfection, and for disinfecting masks, one would use the same procedure. Bob, you brought up off-gassing a moment ago, and this is the other big issue. It is important that we ensure that any residual hydrogen peroxide off-gassing is sufficiently low enough that the next person who wears that mask does not breathe in hydrogen peroxide vapor. We've already discussed that hydrogen peroxide vapor is highly toxic. Otherwise, it would be no good as a sterilant. So off-gassing has to be done in a very well-ventilated area. And again, people should only enter that area once the hydrogen peroxide concentration is below the OSHA permissible exposure limit. The masks themselves then have to be tested to ensure that the off-gassing is low enough for the mask to be returned to service. A simple procedure that can assess the off-gassing is to place the masks that have aerated after disinfection into an approximately airtight container. Place a portable gas monitor with a sensor for hydrogen peroxide inside the container and close the container. Wait for about 30 minutes for the hydrogen peroxide inside to equilibrate and take a reading. If the reading is less than 0.2 ppm, which is about 1/5 of the OSHA permissible exposure limit, then the mask can be released for use. If the reading is higher than 0.2 ppm, then the mask should be removed from the box, laid out in the well-ventilated area again to off-gas for at least another 2 hours, and then the process can be repeated. Now, we chose the 0.2 because, as I said earlier, the OSHA permissible exposure limit is 1 ppm, and this gives us a 5-fold safety margin.
That's a great point, Richard. Thanks. So can you explain what off-gassing means? Do I really have to do it in hospital? I never did this when I was running my own sterilizers.
Yes, sure. Off-gassing is the slow release of the sterilant gas after the sterilization cycle is over. If a steel object were sterilized, the sterilant gas would interact with the surface, kill the bugs, and when the gas is removed, the steel surface is left gas-free and there'll be no off-gassing. Now imagine that we were sterilizing a filter or other high surface area material that the gas would permeate through the material more slowly, get into all the crevices and voids in the material. If the gas is polar, where polar means that it attracts other polar compounds like hydrogen peroxide, then the sterilant gas would absorb, i.e. stick, onto all the interior surfaces of the material. If the material is being sterilized in a sterilizer, there may be a vacuum to remove the gas, or if it is in room disinfection, then just a clean air flush. In either case, it may take some time for the sterilant gas, the hydrogen peroxide, to evaporate off the inner surfaces of the material and make its way out, long after the sterilization process is over. The material is then said to be outgassing hydrogen peroxide, or whatever the sterilant gas being used is. We see outgassing with other types of sterilant gas too. Ethylene oxide, for example, is notorious for outgassing after sterilization. The rate of off-gassing depends on the materials used to make the mask, the gas used to disinfect it, and the conditions. The next person to use the mask has enough on their mind that they do not need to wonder if they are being exposed to hydrogen peroxide. So yes, the mask should be given enough time to off-gas the hydrogen peroxide before they are returned to service. For mask reprocessing using room disinfection, the best option is to use the method just described because of the large volume of masks involved. If a lot of masks are being disinfected using sterilizers, then having too much hydrogen peroxide vapor evaporating into the ambient air is probably not a good idea for the people who work there. It would be better to put the mask into an aerator or into a hood with an exhaust. This will remove the hydrogen peroxide vapor safely. An aerator is an approximately airtight container with a fan and a hydrogen peroxide absorber. so that the off-gassed hydrogen peroxide is captured rather than being released into the room air. If using the hood, then the challenge again is to know when the masks are sufficiently aerated, and the procedure we discussed on the last slide can be used. If using an aerator, then the following procedure can be used. Step 1. Place the mask into the aerator directly from the sterilizer. Place a portable gas monitor with a sensor for hydrogen peroxide inside the container and seal the container. Turn the fan on and wait until the hydrogen peroxide monitor reads below 0.2. Turn the fan off, remove the hydrogen peroxide scrubber, close the lid, and wait for 30 minutes. If the reading stays less than 0.2, then the mask can be released for use. If the reading is higher than 0.2, then place the hydrogen peroxide scrubber back into the aerator and turn the fan on again for at least 2 hours and repeat the process as needed.
So if our gas sensor reads 0.21, which is close to 0.2, can we still release our masks?
Yeah, the OSHA permissible exposure limit for hydrogen peroxide is 1 ppm, calculated as a time-weighted average. Since the mask is directly on the wearer's face, they are going to breathe in any off-gassed hydrogen peroxide, potentially for several hours. We recommend using less than or equal 0.2 ppm, since this provides a reasonable safety margin. Therefore, if the reading is above 0.2 ppm, the mask should be aerated for longer. However, a facility can use a different value if their risk management committee reviews the available data and using a documented procedure determines that a different value would be better. There are some other considerations regarding reprocessing to think about. The time needed for aeration depends on the materials the masks are made from, the number of masks, and how they were packaged and packed, etc. So it is possible to go and reduce the aeration time by making sure that there's plenty of space around the mask so they can aerate well. The aeration times described are just guidelines, and the optimum time will vary with specific conditions. But by using a hydrogen peroxide monitor, one can optimize the aeration times needed to bring the off-gas hydrogen peroxide concentration down to safe levels. It is recommended to use a monitor that has separate wireless, e.g. Bluetooth sensor that is connected to the exterior of the container, and a separate display where one can read the concentration. This is particularly useful in the examples where we've talked today, such as checking that the concentration inside a room after room fogging is low enough. You put the sensor aside and you can read the value outside. If we want to look at the off-gassing, we put the sensor in the box and we can read the value outside. There are other challenges that facilities need to consider when reprocessing N95 masks. In particular, it needs to be a dedicated space. The mask should not be sorted in the prepped and packed area of a sterile processing department, since they are contaminated and risk contaminating the environment where surgical instruments are exposed to the air. Conversely, since the masks cannot be cleaned, they cannot be taken into the decontamination room, since they may absorb or be exposed to additional contamination. Therefore, a dedicated space for reprocessing the N95 masks is needed. At the moment, hydrogen peroxide looks like the most promising disinfectant chemical, but it is not the only chemical out there. And other methods using other disinfectant chemicals are also being developed. The prime candidates are those for which there are vapor generators already available for room disinfection, using compounds that do not leave any harmful residues, especially ozone, chlorine dioxide, and peracetic acid. If these chemicals are used, then the same issues concerning when is it safe to re-enter the room and determining the extent of off-gassing from the disinfected mask are the same.
So one question that is most certainly going to come up as sterile processing professionals interact with this information, as they run these masks that are contaminated with COVID-19 that have been disinfected, as they run them in their Sterat or their vPro, do they need to re-clean the sterilizer before they begin running their regular loads again? And there are devices like batteries and light cords and cameras and things like that they're typically running every day.
Yeah, good question. Even though the masks have not been cleaned, each one should be placed in its own Tyvek pouch or equivalent. And so the risk of grossly contaminating the Sterat or vPro sterilizer is so small that in most cases cleaning should not be necessary before using it on normal loads. However, if there is any visible residue after disinfecting the mask, then the sterilizer should be cleaned.
So another common question that may come up is, should my hospital have an area monitoring device for H2O2? Am I in danger if we don't have an area monitoring device?
Another good question. Hydrogen peroxide is a very effective sterilant. And so hydrogen peroxide vapor is toxic to anyone exposed to it. If it were not toxic, it would not be a good sterilant. As discussed earlier, the OSHA permissible exposure limit is 1 ppm, calculated as an 8-hour time-weighted average. Modern sterilizers are made to exacting standards. If a sterilizer has a few hundred or a few thousand cycles on it, there's an increased risk that there could be a leak. As the hydrogen peroxide annex in AMI's SD58 says, emissions from properly operated and maintained chemical vapor sterilizers should be well below the OSHA PEL. But sterilizers and exhaust systems, as with other complex equipment, can and sometimes does fail. Hydrogen peroxide has essentially no odor, and so if there was a leak, users would not know until it was so high that it was stinging their eyes. Some models of sterilizer do a better job of removing hydrogen peroxide vapor at the end of the cycle, and others not so well. For the latter, having a cloud of 20 to 50 ppm hydrogen peroxide come out of the sterilizer when the chamber is opened is not unusual. We recommend placing a sensor directly over the sterilizer door, and at the end of the cycle, the operator will open the door and step back and watch the monitor reading. Once the monitor indicates that the hydrogen peroxide has dispersed, the operator will then unload the sterilizer. A monitor will provide protection from small leaks from the sterilizer in normal use, and protection from the unexpected leaks due to malfunction, wear and tear, and human error. So yes, it is recommended that hospitals monitor for hydrogen peroxide.
Okay, so let me ask a big question here. Why is it not required to have area monitoring in healthcare facilities if we know that it's causing danger to their employees?
Yes, thanks, Bob. This is a very common question that we get. And the answer is that OSHA sets requirements, but normally does not dictate how those requirements are to be met. OSHA's requirement is that employers must ensure that their employees are not exposed to hydrogen peroxide above the OSHA permissible exposure limit. But how employers achieve that is up to them. OSHA takes this approach because if they were to specify a technology, they risk the regulation becoming obsolete. The OSHA regulations were written in the 1970s, long before the first hydrogen peroxide sterilizer, and back then hydrogen peroxide in air would have been measured using an impinger or a bubbler, followed by chemical analysis. Today we have gas monitors that give a near instantaneous reading that give continuous protection because conditions change, often unexpectedly. To answer your question, there is no requirement to monitor for hydrogen peroxide, but there is a requirement to ensure that people are not exposed to more than the OSHA PEL. Since hydrogen peroxide vapor is colorless and has no odor, how are employers going to show their employees are not being exposed to hydrogen peroxide vapor without a real-time gas monitor? The COVID-19 pandemic has caused a crisis in healthcare, and particularly for the healthcare providers, the lack of PPE, especially N95 masks, put them at direct risk. Even restricting the availability of masks to those deemed critical frontline providers and extending the use of masks when attending multiple patients has not been enough. However, in the short time that this crisis has been with us, it is remarkable to see the level of innovation that has been applied to find solutions to this problem from all walks of life. And people have come up with ways to reprocess used masks by disinfecting them in a way that does not reduce the fit or effectiveness of the mask. The most common approach to disinfecting masks is hydrogen peroxide, either using hydrogen peroxide sterilizers from companies such as ASP or Steris, which can offer a reliable technology but can only process fairly small volumes of masks, or room fogger technology that offers much larger volumes of masks processed per cycle, but the technology is less certain and less available. Using hydrogen peroxide, however, poses risk for both methods, but especially for room disinfection. Hydrogen peroxide is, of course, toxic and has no smell. How does one know when it is safe to re-enter a room? The answer is to use a portable gas monitor for hydrogen peroxide. Similarly, residual hydrogen peroxide in the mask present a risk of exposure to hydrogen peroxide to the next wearer, and the combined outgassing from large numbers of masks presents a risk to personnel reprocessing the mask, And again, the gas monitor provides the simplest solution using the protocols that we have suggested. We hope that this presentation has been useful to you. We welcome your questions and comments. Please reach out to us directly.
The handout provided includes the paper written by Richard Warburton and also provides the 3 procedures outlined in this presentation as handouts that can be printed for your department as a reference. If you have specific questions concerning the content of this webinar or the paper, please reach out to ChemDAQ directly through social media or via email at monitor@chemdaq.com. To all of you fighting this pandemic on the front lines, please do everything that you can to protect yourselves and your colleagues. And on behalf of Richard and myself, we want to thank you for joining us and just encourage you to continue fighting dirty.